Hey guys, we are going to be talking about creating a nursing care plan and nursing diagnosis for your patient in less than 10 minutes. I want you to head over to nrsng.com/care plan template to download the free care plan template that the NRSNG team has created for you guys. I'm going to be covering a few of my personal tips and tricks that I have on when you get stuck on doing a nursing care plan and you're like, I literally have nothing. I don't know what we're going to do for this patient. I have a few kind of things that I just go over every single time for every patient to make sure, usually that patient has one of those things that you can write about. So, all right, I am going to start off by showing you our care plan template. So this is what you should download at nrsng.com/care plan template. It starts off in the left column. You will write your nursing diagnosis and, or plural, you can have more than one. You will then write down patient goals, then interventions and the rationales behind your interventions, whether or not you implemented them throughout your shift. And this is based on your shift. If you are not able to implement it, just because you have a plan to do something might come up, you may not be able to implement it. That's okay. It's not a failure to put no. Sometimes it's not appropriate. Sometimes you planned for something and the patient took a turn for something completely different. So the other thing is the evaluation and the outcome of your nursing interventions. So I'm going to read off a little bit of a patient assessment for you, and then I'm going to go through my thought process on getting a diagnosis and a care plan put together for you guys. Patient presents to the emergency department with complaint of a suicide attempt. I know this is a little dark, but this happens all the time. Per patient's mother states, I walked into his room and I found him with a rope wrapped around his neck. He was standing on a chair and I yelled, "Jack!" He looked up at me and kicked the chair out from under his feet. I grabbed the rope and yanked it down off of the ceiling fan. End quote from mother. The patient reports that he had been feeling really sad ever since his girlfriend broke up with him a couple of months ago, and today they were texting back and forth. He texted her and she said to stop contacting her and that she wishes they had never met. So upon an inspection of his neck, there are visible bruising marks from the noose on the underside of his chin and on the sides of the neck, but there aren't any broken skin wounds or any bleeding anywhere. The skin is completely intact, and the patient also has, as well, multiple crosswise cuts on the wrist bilaterally. That mom nor patient hadn't really talked about, that you just noticed upon inspection. So no bleeding of the wounds, but they do look fresh. They do look like they've happened recently. The patient is alert and oriented ×4. The lung sounds are clear to auscultation and they are even and non-labored breathing. The heart rate is normal sinus rhythm, +3 radial pulses that you can palpate despite the cuts on the patient's arms, or wrists, I should say. The patient denies any pain at this time. There's no signs or symptoms of distress. The mother and the sitter are at bedside, and the patient has had suicide precautions initiated for the patient. So, where do I go with all of this information? We start off kind of by thinking about the obvious thing. This patient is a suicidal patient. We want to be thinking about suicide precautions. So for my nursing diagnosis, and I'm going to zoom in here for you guys. Oops. There we go. I wrote risk for suicide related to suicidal ideation, depression, and lack of coping skills, as evidenced by suicide attempt via cutting wrists and hanging with a noose. So basically I just went and I looked at, does this patient have, the obvious suicide risk for suicide? And that's one of the NANDA international nursing diagnoses it is. Why is it that they are at risk for suicide? Well, because they attempted suicide, and it's evidenced by the cuts and also by the noose and the bruising on the neck and things like that. The subjective data is that the patient stated, I want to kill myself. Life isn't worth living. I hate it here. These are kinds of things that he had said to you at one point. And also, if I had more space, or if I really wanted to get detailed, I could put what the mother stated, that the mother witnessed him, with the noose around his neck and falling off of the chair. The objective data is that the patient has cuts on the wrist from recent cutting and has bruising around their neck from the noose. So from here, we've written out a diagnosis, the main one, risk for suicide. The goals for this patient are obviously to prevent them from committing the suicide. We want to create a working therapeutic relationship. I think that's really going to help with getting the patient, bridging them to where they need to go, and then involving social work to coordinate long-term mental care. Really, as far as like physical patient goals, it's not like you can say, oh, I'm going to be monitoring fluids or vitals or anything like that. This one's more of a mental aspect. And, the main obvious aspect that you want to do is you want to prevent the suicide. That's your biggest goal throughout the shift. But a way to prevent it is to also get within their brain and think about the things that they have going on. So you want to create that therapeutic relationship. For interventions, I put down that, here, I'll do it that way. We want to implement the suicide precautions. So a one-on-one sitter. Even if mom or any other family member is present, you want somebody who is trained to sit with that patient and look for warning signs and knows, our hospital policies or whatever. Make sure that if a food tray gets accidentally delivered with, let's say, a knife on it, you want to make sure that that person is able to pick up on that if you don't pick up on it right away. You want to remove anything that the patient can harm themselves with. So all of the cords that we have to our monitors, our call light cord even, pens, equipment, anything that patient could use to harm themselves or to harm others, you want that all removed. And you remove personal belongings. And this is something that is non-negotiable in every establishment that I've ever worked in. You remove everything, their cell phone, any sort of outside resources. You don't just let them have their purse sitting at the bedside if it was a female, or their backpack, let's say. You don't know what's in that backpack. They could have pills, they could have anything in there. So you remove everything. That way there's no argument. You just remove all of their personal belongings. And then you place that patient into a special gown so that it looks different than other hospital gowns, in case they have any sort of flight risk or any sort of escape, anything. You want to be able to easily identify that patient. And then another intervention is listening to the patient. That is going to be the best way to create a therapeutic relationship with them, is to listen to them and hear their concerns, address their concerns, validate their concerns. That's probably one of the even bigger ones, is validating. Like when he says, my girlfriend texted me, she doesn't ever want to talk to me again. And you're like, yeah, that sucks. Instead of being like, well, you should have done, this other thing, or don't let that bother you, validating them, let them know it's okay to feel that way. Yeah, it's okay to be angry about that. And then making sure that their basic needs have been met. That's something that you definitely want to make sure on a suicidal patient, is that you've addressed things like eating, voiding. Have they done the things that normal people need to do in order to survive throughout a day? And also you want to make them comfortable. Are they cold? Do they need blankets or pillows, or what can I get them to help them be comfortable? And at least help them throughout the situation that they're in at the moment. Throughout our shift, we'll say, yes, we implemented all of these things, or we were able to implement them. And then for outcomes, I wrote patient remained safe without injury during their 12-hour shift. The patient shared stories about feeling sad and background to their feelings, kind of dug a little bit deeper. What's going on with his girlfriend? What is it that really triggered this text message interaction to happen? And how often has he been contacting her? And what, all the different things that were going on to really trigger this. And is there any sort of family sort of aspect to it? Did the family really, are they involved? Does the patient feel like they are, involved in his life, or however that may go about? The patient had lunch and dinner at appropriate times. So again, and I want to step back here and talk about patient remained safe without injury during 12-hour shift. So I stated what it is the outcome was, and I gave it a time frame so that we were able to measure it. That's super important that you give a time frame. So he remained safe. There wasn't any injury, and it happened in a 12-hour shift. Same with the lunch and dinner, happened at appropriate times. Patient voided and had a Brown formed and normal bowel movement today. So that gives a time frame as well. So that basically says, yes, we did do the outcomes, and it gives you a nice, even like you can just go right across the board and write everything and even line it up a little bit. So we're preventing suicide. How are we preventing suicide? Well, so our patient goal, prevent suicide. We want to prevent suicide. How are we going to prevent suicide? What are our implementations? Well, it's right across, so it's the next thing. And then over here with our evaluation, our outcome. Yep, that happened. Next, created a working therapeutic relationship. How did we do that, or how did we plan to implement it? We listened to the patient. So down here, and then the next thing on this list is the patient shared stories about feeling sad to background, and so on. So that's just a little bit about how to use our care plan template. And then I wanted to kind of go over these 4 things here, really 5. If you're ever stumped and just really need to have a diagnosis and you really can't think of anything, or you're not sure where to go, I always would rely on FALS, your ABCs, mentation, pain, and poop. So instantly, when I think of a patient, I think they're probably a risk for fall. It's almost like you have to convince me they're not a risk for falls. So this is the number one thing that I would put on almost all of my patients' diagnoses and plans. Next, you want to address their ABCs. So airway, is it patent? Breathing, is it even non-labored? Are we okay? Were there any sort of like noises that I need to address? Is there anything that I can address with their breathing? And then for their circulation, you want to address circulation, pulses and capillary refill, their heart rate, was it normal sinus rhythm, things like that. Mentation, if they have an altered mental status, or if they are having depression, anxiety, or suicide attempt, as this one is having a suicide attempt, things like that, you want to think about next. And the last one is pain or poop. And I wrote this FAMP, FAMP, for your mnemonic to think about there. But pain, you have acute pain and you have chronic pain, and it happens, but it's rare that a patient will come in and be completely and totally free of pain. So you can usually write something about the pain that they have going on. And another one that's super important is poop. So if your patient is coming in and they haven't had a bowel movement, why haven't they had a bowel movement? Or what do their bowel movements look like? Or what is it that's going on with that? Does their abdomen hurt? Things like that. So those are my fallback things that I tend to chart on. for my nursing diagnoses, or that I think about right away for my nursing diagnoses. Another one that you may want to stick in there, or that most floor nurses would be thinking about, is skin. There's usually a risk for some sort of skin breakdown or immobility or anything along those lines. So those are my tips and tricks on how to get a nursing care plan in under 10 minutes.